really excited to be joined by Commissioner Robbie Goldstein for a conversation about moving from buzzwords into action. Thank you also to those of you who submitted questions ahead of time for the Commissioner. We've peppered some of those in to this segment. We'll also have time for audience questions at the very end. So if you have other questions that you haven't had a chance to ask yet, or something comes up while you hear the conversation, please use the Q&A feature at the bottom of your screen to put questions in to the panelists, and we'll select as many of those as we can get to. So without further ado, I'd love to first introduce Commissioner Goldstein. Dr. Goldstein was appointed as the Commissioner of the Massachusetts Department of Public Health by Governor Healy in April of this year. Dr. Goldstein is an infectious disease physician by training and previously served as Senior Policy Advisor at the CDC under the leadership of Dr. Rochelle Walensky. Prior to that, he founded and was Medical Director of the MGH Transgender Health Program. Since his appointment as Commissioner of Public Health, Dr. Goldstein has shown himself to be a champion for and a partner in our long-term campaign to transform the local public health system. He is also responsible for creating the position of Assistant Commissioner for Health Equity and for appointing Dr. Jop, who you heard from earlier today. Welcome, Commissioner Goldstein.
Thanks for having me. I'm excited to be here.
Well, let's dive right in. You've been in your role for, I did the math and have already forgotten it, but I think about 6 months now. Seven months?
Yeah, 7 months
Amazing.
tomorrow. Not that I'm counting the days.
Happy 7-month anniversary.
Thank you.
Tell us about your vision and priorities for the Department of Public Health and public health in Massachusetts writ large.
So, first I'll just say thank you for having me, and thank you for giving me an opportunity to talk to folks. I think many folks on the call maybe have heard me speak at various events, and I have been trying to articulate over the past 7 months a bit of a vision that I have for public health. And to explain where that vision comes from, part of it is that I've been in Massachusetts for a long time. I've had deep respect for Massachusetts and the Massachusetts public health infrastructure that exists. I've seen that as a resident in Massachusetts as part of the Commonwealth. I've seen that as a clinician who was caring for patients and was reaching out to the public health infrastructure to try to make sure people had the resources they need. And I saw that when I was at CDC. And at CDC, I had this really unique opportunity where I had a knowledge of what was happening in Massachusetts. I could celebrate the successes and the wins in Massachusetts. And then I could also go out to other parts of the country and recognize who was doing it well and who maybe wasn't doing it so well. And so when I had the great fortune to have this job as commissioner, and it was coming in and thinking about priorities and strategy, I tried to bring all of what I had learned at my time at CDC and what I knew were the strengths of Massachusetts public health infrastructure to articulate 5 key priorities for the department. And I call those priorities fundamentals of public health. And the reason being is that what I saw around the country was that successful public health departments and successful states had really invested in the fundamentals. So what are they? The first is a commitment to health equity. And I think this department, this state has been committed to health equity. It's put it central to much of what we do. But I wanted to be very explicit that our work was going to be focused on health equity and advancing health equity beyond just the words, which is what we'll get into today. The second is a commitment to emergency preparedness and response. I think it's not lost on anyone. We just went through the largest pandemic that any of us have experienced over the past 3 years. Our emergency response infrastructure wasn't what it needed to be. It wasn't what it needed to be across the country and not here in Massachusetts. We needed to invest. We need to continue investing. But I've challenged the department to say emergency response and emergency preparedness is not just about preparing for pandemics. It is about recognizing the changes associated with climate change and the impacts those may have on public health. It's understanding the threats to reproductive health and gender-affirming care. Those are true threats and emergencies that we need to deal with as a public health infrastructure. The third fundamental is an investment in our workforce. I'm talking to a group of people who are part of the public health workforce as our greatest asset, and we have in many ways neglected that asset over the past few decades. We need to recruit, retain, sustain a workforce that is resilient and is ready for whatever might come next. The fourth fundamental I talk about is our infrastructure, which if for anyone who's been to parts of DPH, it's definitely our physical infrastructure. We have some work to do, but mostly what I'm talking about is our data infrastructure and the need for us to move into the 21st century and have the data available that are going to inform our public health decisions. And then last but not least is a commitment to public service. We choose this, whether we're in government or not. All of us in public health are part of the public service infrastructure. And that means we need to honor that commitment, and we need to really invest to make sure that we are communicating with the right stakeholders, we're engaging with the right people. The work that we're doing has the biggest impact that it can have on the communities most impacted.
Thank you for outlining those key priorities. I know we have a couple of questions coming on health equity and some of the other points that you raised, but I do want to follow up on what you said about workforce. I think in the public health field and in general are feeling very deeply that it is a very challenging time for workforce issues. A lot of the public conversation in the health space is about the healthcare workforce, where there certainly are these same challenges, but I know that you share MPHA's view that that conversation needs to be expanded to include the public health workforce. We've seen a lot of attrition, I think understandably during and since the pandemic, given just what the local public health force was asked to do and the ways in which those jobs became very politicized in this time. Can you speak a little more to how you're thinking about those issues and how you're building that pipeline?
Yeah, thank you for highlighting that. Too often the conversation around workforce is focused on what's happening inside the four walls of healthcare. And that is really important. I don't want to take away from that. We are facing record shortages for nurses and CNAs and every level of healthcare is facing record shortages. But what's lost in that conversation is that going into the COVID pandemic, we were already in public health around 60 to 70,000 people in deficit in our workforce. We had a brief increase during the pandemic, at which point some one-time funding allowed us to bring in some folks, but that funding is going away. And many people have already left those jobs because of the experience, the trauma of the past 3 years. We need a better way to recruit and retain people into public health. I think we do that partly by making sure that we're investing in communities and we're showing communities the value of public health. I think there's a long-term strategy here, right? We can get youth, adolescents, young adults to recognize the power and value of public health. We can get them to be excited about this career path and move into this. Once they get here, we need to pay them what they're worth. We need to pay people reasonable salaries for the jobs that they're doing. This is incredibly hard work. I think it's challenging. Public health faces not only record workforce shortages, but record dollar shortages too. We see the boom bust that happens in public health funding. I've been really trying hard within the Department of Public Health, within the Secretariat, and all of my visits to the State House to make the point that we have to start paying public health workers what they're worth. We cannot continue to underpay a workforce that is working so hard to protect people, because the result is that people will leave. People have showed us, right? They'll show us with their feet, they'll leave, and an emergency may come and we will not have the workforce that we need, whether it be at what we call DPH Central, right? The State Department of Public Health, or the local regional public health groups that exist. We will end up with not enough people to do the work that's necessary. And I'll just say one other thing about workforce that I think we all have a role to play in this is that we have to recognize that the workforce in public health is changing. This sort of traditional epidemiology will always be important, and we always need to invest in that. But we are operating in a very different space in public health now. And to work in public health means that sometimes you have to have an understanding of complex genomic analysis and sequence analysis to understand what's happening rather than the traditional epidemiology. Sometimes working in public health is being the community health worker who's embedded in one of our shared service agreements and is sort of on the ground helping to bring people together. public health is not what it was in 1970, 1980, 1990, and our workforce has to reflect that now.
Thank you. I want to move us in a different direction, but I just want to add, I think to that, I think your point is well taken about paying public health workers what they're worth. And I think that's also, we can't divorce that from the conversation about Massachusetts's enormous housing issues, and that even good salaries are not enough to help people meet their housing costs. And we think of that so at MPHA, we are working on that. It's a priority of ours. We think of that so much from the perspective of social determinants of health, but of course it is also, as an employer, a huge issue that we are facing, where our own staff are being pushed out of the city.
Absolutely.
Switching gears a little, although of course it's all related, our theme this year for the conference is Beyond Buzzwords, Action for Health Equity. Can you speak to how you are thinking about health equity, both within the department as an employer, and the ways in which that the department partners with communities, and externally?
So, I think about this a lot. I think it's really easy to put out the words. It is really easy to say the words. We're invested in health equity. We're committed to health equity. We're going to pivot towards an agenda that is focused on health equity. I think the action is what's most necessary. Folks, you announced this already, and you've already met Dr. Diop, or many of you have met her before, and now you got to see her on a panel here. The idea to create a position, an assistant commissioner for health equity, is the first step in taking action. I thought about this for a long time before we made that decision to create the role. I talked to a lot of private commissioners, to a lot of people who worked in the department, around the department. I want to be clear that the Department of Public Health has for a very long time been committed to health equity. We didn't need an assistant commissioner to say that we were committed to health equity. What we needed an assistant commissioner for was to hold us accountable, was to have somebody whose job it was to hold me as the commissioner accountable, to hold our other assistant and deputy commissioners accountable, to hold the 3,200 people that work in the department accountable to our health equity and our racial equity goals. And so as Dr. Diop moves into this role and begins to expand, certainly she's doing a lot of amazing things around the work that exists underneath her, our Vaccine Equity Initiative, our Office of Health Equity, our Office of Problem Gambling, the Interagency Health Equity Task Force. But where I think she's going to be most critical and most impactful is in the way that she holds us accountable. So I want to say that role, the creation of that role, was taking action and setting ourselves up for further action. But it's not enough to just create that role. We're doing a lot of other work to move us beyond those words. We're thinking critically about what is it that our workforce needs to know, understand, and internalize to do the work of health equity and, importantly, racial equity. What are the trainings that need to be done? How do we hold people accountable to those trainings? How do we set up the right systems so that when people experience or witness work or activities that are not what we want the department to reflect, how do they have a feedback mechanism to make sure that we make changes? We're putting in the time and the effort now, and with Dr. Diop's leadership and with my backing, we are then going to hold the department accountable to those. We're also thinking about how do we go through every data infrastructure we have at the department and include the right data so that we're collecting the right information and we can use it as we move forward our health equity agenda. All of these pieces, I think, are us moving beyond just saying the words that we are committed to health equity, that we want to advance our priorities on racial equity, but that we are actually going to do this work. And we're incorporating all of it into our strategic planning processes. For folks who know things about the Executive Office of Health and Human Services, we're actively going through a strategic planning process right now. We have made it very clear that every box on our strategy map will be inclusive of health equity and racial equity. It is driving our mission, it's driving our vision, it's driving the work that we're doing. And then our outcomes and our measurements and our accountability structure are going to keep us true and honest to that.
Thank you. Thank you for that, Commissioner. Quick reminder to folks who are tuning in, we have about 300 people listening in today. Please, as you have questions for the Commissioner, put those into the question and answer feature at the bottom of your screen. We'll turn to audience questions in a couple minutes. Commissioner, you just raised data. The previous panel, which Dr. Jeff was on, was talking about how different public health practitioners in different kinds of roles in the community through advocacy in the department itself are using data to take action and advance policy that closes health equity gaps. We know, of course, that we cannot manage what we don't measure, and the availability of good data in as close to real time as possible really helps those of us on the outside, and I'm sure those on the inside as well, advance policy. We saw that certainly during COVID. The department's data on overdose deaths has already changed the conversation in the State House around overdose prevention. Can you speak to what the department is engaged in right now to make more data and better data available in a more timely manner?
Yeah, I'm sort of smiling because the folks within DPH are probably sick of me saying this. When they come to me to brief me on the data that we're putting out in the department, I always say, and why don't we have more updated data? And why don't we have the next month or the next 6 months or the next year of data? We are trying to move ourselves into a different space with our data release. We have historically put out really comprehensive data sets that, as you mentioned, I think are really impactful. I think they change the conversation in the State House. They change the work that can be done across Massachusetts. But too often, the data that are coming out are too old for us to take action. They are from 2 or 3 years ago, and they're not as useful as we would want them to be. I'll say I'm really proud that we put out the severe maternal morbidity report that came out this past summer. And I pushed because the report only goes through 2020 and it's 2023. And we need to know what's been happening over the past 3 years, right? So that push, I think, is really important for us. How do we do that? We do that by modernizing our infrastructure. Right. Data modernization is an enormous project at the department, and it's a priority. And I came in on day one and said to the team here, I want to be engaged in data modernization because this is how we get the right information out to the right people at the right time so that our policy work can move forward. It is hard. It is really, really hard to do data modernization. I'll just sort of throw this out there that, when MGB went to update their medical record system, when they went to go do a data modernization project, they spent $1 billion as a one-time investment and continued to spend money on a yearly basis to keep their data infrastructure up and running. Now, that's one health system in Massachusetts. We have nowhere near that much money in the Department of Public Health to try to update and modernize our data infrastructure for the entire Commonwealth. So we are thinking really critically, how do we utilize the money we do have? How do we improve the systems? How do we work with others within the Secretariat and others across state government? And importantly, how do we work with people out in the community to make sure that we have the right data coming in, the right flow of information, and that we can get the data back out? One big piece of that, which I think we might talk about, I don't know if we will, is SAFE 2.0. Right, is this understanding that for us as a state to have the right data, the cities and towns need to provide those data to us. And we need to invest in their infrastructure. We need to invest in their personnel. We need to invest into building the system that we need so that we can understand the health of the Commonwealth.
Yeah, thank you for that answer. And I think I would love to go down a little bit deeper on SAFE 2.0 and local public health infrastructure. This is something, of course, that is a huge priority for MPHA, and I know the department, and we've been working on this campaign for many years. The campaign predates both you and I in these positions. One of much of what we've talked about today is key to that piece of legislation: workforce development, that kind of pipeline for local public health and data modernization as well. Can you, I just would open the floor for you to speak about how how you think that's going. What are you looking forward to, and how is the department, I think, is already thinking about implementation? Of course, the bill hasn't passed, but ARPA money was allocated, and so some pieces are already underway.
Yeah. Yeah. So maybe I'll start by saying, again, let's talk about some action that we have done and we will do, continue to do. One of, in addition to creating the Assistant Commissioner for Health Equity role, one of the other changes that I made coming into the department was to elevate the Office of Local and Regional Health to report directly to the Commissioner. I thought that was really important to do. I thought it was a representation of the importance of local and regional health, that it should have a seat at the executive table at the Department of Public Health. I think, also it was a recognition that we have a lot of work to do, and I want to be engaged in that space. And I need that direct connection with the Office of Local and Regional Health to help steer some of these things through. So that's one action step that was taken to show the investment here. I think many folks here know that in October, in our Public Health Council meeting, we released the standards for local public health, the first ever standards for local public health here in the Commonwealth. That is part of SAFE 1.0, the first version of the bill, and SAFE 2.0 would give us, hopefully, the resources, sort of the carrot and the stick that are necessary to make sure that we can actually implement those standards and get those standards done well all across the Commonwealth. I think another actionable step here is our investment in the shared services agreements, right, which SAFE 2.0 would further augment, but we already are pushing forward. I don't have up-to-date numbers from today, but as of most recently, 321 cities and towns across the Commonwealth were engaged in shared service agreements, which is starting to bring people together for shared expertise, shared understanding, this whole concept of never worry alone. Like, you don't worry alone. If you're one small town, you have others around you to help support you in your local public health efforts. We are pushing forward with those. So we're going to keep doing that, whether we're, SAFE 2.0 passes or when it passes, however this happens, because we think it's really critical to continue to build that up. But SAFE 2.0 is an opportunity for the Commonwealth, the government, to demonstrate the commitment that it has to local public health, to give that carrot, right? To give some of those resources that are necessary to get this important work done.
Thank you, Commissioner. And I'm going to talk a little bit more about SAFE 2.0 in the next session. We are ever hopeful that any day now. It is actually quite close to passing, and so we are hoping to see that finally cross and stay over the finish line. So we can get to implementation. We have a couple of audience questions that I'm going to move to, and would encourage people to keep putting questions into the Q&A feature if you have them. One person asks, what is the best way to access the data sets that already exist that you referenced that are being put out by DPH?
That's a great question. And it's something actually that is part of our data modernization initiative, which is to make the data accessible to everyone. I work within the department. I've worked with the department's data. It's sometimes really hard to find. It's not easy to go to our website. I think we're doing a better job with things like the transparently sharing the data around severe maternal morbidity, transparently sharing data around opioid-related overdose deaths. We've updated our FIT tool, our population health information tool that I think is helpful to get data out and for people to easily access. But we are working through data modernization to make it even easier for people to access the data sets that they need. That's not a great answer for right now. And I think that folks, academics, researchers, people in organizations who want access to data and need it, I think it is our responsibility to respond to your concerns and your asks. And so I would say ask for it and we'll get you the data that you need, because we recognize the importance of bidirectional flow, us sharing it with you, you being able to share your results back with us.
So I think the invitation to reach out to the commissioner, to the department for the data that you're looking for, and stay tuned for exciting updates, and yes, also sign up for MPHA's list whenever we get news and announcements from the Department of Public Health. We are pushing those out. So stay tuned for more. I know, Commissioner, that there were 2 reports that came out yesterday related to some of what you've touched on maternal health and essential services. Can you tell folks on the call more about those 2 reports?
Yeah, happy to. So as many folks may have seen and heard and read, on September 22nd, the governor asked the Department of Public Health to pull together 2 reports. One focused on what are called essential health services in the North Worcester County area, and one on maternal health services all across the Commonwealth. These were in some ways a direct result of the closure of the maternity unit at Health Alliance Leominster. Although I think these were necessary reports and necessary work for the department to do to make sure that we understood healthcare, public health all across Massachusetts. So I'll just say briefly, the essential services report, while really focused on the North Worcester County area, brought up issues that I think are relevant to all of the Commonwealth. Issues related to transportation and travel times. I know MPHA has been a strong advocate for improving public transportation and the importance of transportation in public health. And we called that out as a specific barrier to health access and health care in North Worcester County. We talked about the cost of living here in Massachusetts and the need for better pay equity for people in public health and in health care, and to make sure that we're including things like housing costs, transportation costs, as we're thinking through the workforce that's needed. So I think it's a really strong report that had very specific actionable recommendations about how we as a department can better serve the Commonwealth. The maternal health report was, and I want to just take a moment to thank the team led by Dr. Diop, who put together this maternal health report. It is, I think, an incredible document. It's a document that takes a comprehensive look at maternal health here in Massachusetts, looking not just at what happens in birthing centers, but what happens in prenatal care, postpartum care, reproductive health, what's happening in all parts of the Commonwealth. It really dives into access to care, perceptions of care, in particular, the perception of care of Black and brown birthing people, who we know experience racism in the healthcare system. And we know that that racism directly results in poor outcomes. And it really challenges us as a Commonwealth to address those specific concerns. And in that report, we put out 25 action-oriented recommendations that we think are the blueprint to better maternal health all across Massachusetts. And I'll highlight just a few things from it. One, we talk a lot about where birthing care is delivered in Massachusetts and who delivers that birthing care. And we made a commitment as a department to look to open up our regulation around birthing centers and open up our regulation around certified nurse midwives to promote the use of birthing centers and to make sure that nurse midwives can operate at the full scope of their practice. We talked about doula certifications to make sure that doulas can be an active part of birthing care. We talk about opening up our healthcare regulation around levels of maternal care, work that Dr. Diop has led in collaboration with many across the state to really make it clear that there are levels of maternal care, and level does not equate to quality of care. It equates to what might be the best place for you as an individual to deliver your baby. And we want to make sure that we put that through the regulatory process and we put that through a broad education campaign. We think it will have really dramatic and specific effects on maternal morbidity and maternal mortality and the overall perception of care. So I'm really proud of both of the reports. I think that they present, and they presented, past tense, we shared them with the governor yesterday, but they presented the governor with a blueprint to improve health all across Massachusetts.
That's sounds very exciting and promising, and we'll hope to see a lot of those recommendations put into action. You have, I think, something of a tagline that I've seen and heard you say in many different places, that hard things are hard and we can do hard things. Yeah. What are some of the challenges that you're facing, surprising or maybe not, in this new role? Well, 7 months, not so new.
7 months, yeah. I don't think I get to say I'm new anymore. I think, I mean, you know this because you've been in my office. I have on my desk a plaque that says "Hard things are hard," and there's not a day that passes by that I don't look at that plaque and just remind myself that this is really hard work that we're doing. This is sort of the question that people ask me all the time: what keeps me up at night? So much keeps me up at night. I was actually joking with someone yesterday that we should do a time lapse of my face every 6 months in this role to show how much hair I lose, how much more gray hair I get, and the sort of wrinkles and bags that form underneath my eyes. There are just huge things that are challenging this Commonwealth right now. First, the thing that comes to my mind is our emergency assistance program and what is happening right now all across Massachusetts. I think yesterday I had an amazing opportunity to go. There's a week-long program for work authorization that's happening here in Massachusetts, and we set up a vaccination clinic within the authorization site, and we are vaccinating around 100 people a day for COVID and for flu, people of all ages, and it's incredible work, and I'm so grateful that the department gets to be a part of it, and it's so hard. It is so challenging to make sure that we can get resources out to everyone who needs them, and that we're able to think not just about, can we get a flu vaccine into your arm, but when we're doing that flu vaccine, can we help make sure that you have access to food, that you have access to diapers and to formula and to whatever else you might need to help support your family through the emergency assistance pathway. It's really hard. It is not what I thought I would be dealing with on day one, but it has become increasingly a part of the role and the work of the Department of Public Health. I think I will share that we're not out of respiratory virus land, that as much as we might want to be done with the pandemic is not done with us. And it's hard. It's hard to lead a public health department tasked with protecting the Commonwealth from vaccine preventable diseases, and to have a population that is by and large tired of hearing from us about this disease and these interventions. There's only so much jumping up and down I can do, so much waving of my hands and screaming and yelling, and trying to get the message out. And it's really challenging to know that we have the tools available and they aren't being utilized at the rates that we would like them to be. So there's a lot. There's a lot going on, a lot of really hard things. But the second part of that phrase is really important, right? Hard things are hard, but we can do hard things. And I oftentimes say we can do hard things together, because I think we do need to do this all in collaboration.
I want to turn back to an audience question, and this also came up in several of the questions that people asked ahead of time, but about community engagement and collaboration. How do you think about, and how does the department ensure that community voices are represented in all levels of decision making? I know we hear frequently from Congresswoman Ayanna Pressley that people who are closest to the pain are also closest to the solutions, but often farthest from the power. MPHA is deeply committed in following the lead of those most impacted by inequities and oppression. And I know that I think, Commissioner, that you share that priority as well. And can you speak to how the department and how you are thinking about that kind of work?
Yeah, so I think many folks know we have an active community engagement unit, part of our Office of Health Equity, working collaboratively with our Vaccine Equity Initiative. I've been working with Dr. Diop, and we've been thinking about how do we transition this into a template for the rest of the department. Our community engagement efforts are critical. We could not have gotten vaccine into arms without community engagement. That was very clear, right? I mean, that was part of the problem, that we weren't engaging with the right folks. We had this resource and it wasn't going anywhere. And when we created the Vaccine Equity Initiative, when we did the community engagement work, we saw the benefits there. It is the case that almost every part of the department does community engagement. But what we're recognizing is that we need some shared principles, we need some shared values around this, and we need a bit of an engine, something that's constantly running all the time, whether there's an emergency or not, whether there's an active situation that we need to deal with or not, constantly engaging with communities for that two-way communication. so that when something happens, a new vaccine for RSV becomes available. A new shelter opens up because of the emergency assistance program. We already have those relationships, those trusted, the trust that builds between us and the communities, and that we can activate it in a second and get resources out. The Vaccine Equity Initiative is doing that in many ways and has been so helpful in other spaces beyond just getting vaccines out. It's been helpful in thinking about the emergency assistance program and can we get out into the right communities. It was helpful as we were thinking about the essential services report and the maternal health report, because those community relationships, that engagement, we had kept going. We had kept the engine running, even when we didn't necessarily need them for the vaccine delivery or vaccine administration. So we're trying really hard to set up a system that is a constantly humming engine of community engagement, ready to go at a moment's notice.
We're approaching the end of our time together. As we close out, Commissioner, I want to give you an opportunity for any kind of call to action or closing thoughts that you want to leave with folks. The people who are with us on this call today are MPHA stakeholders and supporters from all different types of public health work. We have local public health leaders, Board of Health members, advocates, community members, lots of students on the call as well. Commissioner, the floor is yours.
Thanks, Omi. I guess I'll, with that audience in mind, I will say this. The department wants to work with you. The department wants to be engaged with you. The department needs your collaboration, your support, your feedback. We are opening up our doors. We're opening up our windows. We're opening up everything. We are opening ourselves up because we want people to come in and tell us what matters most in your community. What is the thing that's driving you to do this work of public health? And importantly, how can we support you in those efforts? Now, we are a huge organization. We're 3,200 people. We're sprawled out across the state. We sit within this big bureaucratic thing called government. It is hard sometimes for us to shift and to move. But what is not hard for us to do is to take the time to listen, to engage, and to welcome you into this process. So please know that I say this to everyone in the department. My door is open. It really figuratively and literally is open. My door is here. And we want you to come in. We want you to share with us so that we can make sure that we're doing things that matter most and are most impactful to people in Massachusetts.
Well, thank you so much, Commissioner, for joining us. I think many of us at MPHA, and I think many of our partners, have really felt that your door is open. You're easy to access. You have shared your cell phone number with, I think, probably too many people. And we are really excited to continue partnering with you to move a lot of this work from more than buzzwords into action and really start to address these health equity gaps. So
thank you so much for letting me have an opportunity to talk to all these great people.
We really appreciate it. I would invite everyone to give the Commissioner a round of applause from wherever you are in the chat at home. Commissioner, imagine 200 and some odd people clapping, and let's assume it was a standing ovation.
Thanks, everyone.